Hi, everyone, and welcome to the Lympha Press Educational Webinar Series. I am Brenda Viola for Lympha Press, and we are so glad we know that you are logging on right now. We appreciate you taking time out of your busy schedules to be with us. We are waiting for Dr. Chuback to be with us. Eric Ansart, the president of Lympha Press USA, is with us right now. And Eric, it's great to see you tonight.
Thank you so much. I appreciate it. Boy, I'm looking at some of our guests that are on. It's just great to see everybody and participate today.
And there's our guest, Dr. John Chuback. It's so wonderful to see you. Though he doesn't really need an introduction, I'm going to give one. One of New Jersey's top vein specialists, board certified in general surgery, cardiothoracic, and vascular surgery, over 16 years of practice as a vein specialist. We've had a great relationship with him for many years at Lympha Press. We truly appreciate not just his expertise, but his heart for patient care. And so without further ado, I am going to just hand you the floor, Dr. Chuback.
Well, let's begin a little bit with this magnificent structure, the heart. You know, as Brenda said, I spent many years studying in medical school and general surgical residency for 5 years and 2 years of cardiovascular surgical residency, doing open heart surgery, thoracic surgery, and major vascular surgery. The heart is an organ only about the size of your fist. And unlike what many of us are led to believe growing up, the heart doesn't actually live on the left side of our chest. It lives right in the middle. And so it's really central to literally central to our existence and to our life and to our well-being. And unlike so many of the organs of the body, which are paired, meaning we have one on the left and one on the right, of course, we only get one heart. And what's fascinating about the heart is, although we only have one, it's sort of two hearts in one because there's a left side and a right side. So you can really think of it as a left and right organ working in unison with itself. So the right side of the heart is the side of the heart that our blue blood is returning to, the deoxygenated blood, the blood that's coming back from all of our organs. And the left side of the heart is where the red blood or the oxygenated blood is being pumped out to the rest of the body. So we can begin right there with this magnificent organ. The first thing to keep in mind is this is a muscular pump, but this is a highly specialized muscular pump. It has cardiac muscle, which is very different than all of the other muscles of the body, other skeletal muscles and smooth muscles. For example, it's magnificently different than skeletal muscle in the sense that all of us who exercise and go through daily life realize that skeletal muscle gets tired relatively quickly. You may be able to train to build your endurance to run a mile or 5 miles or 10 or even a marathon, but eventually your leg muscles will get tired and you're going to have to stop and rest at some point, no matter what kind of condition you're in. But if you think about this muscular pump in the chest, the heart, before you're born, even as a fetus, we see it on ultrasound. It begins pumping, 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 and it never takes a rest. I mean, it's an extraordinary thing to think about. While you sleep, it's pumping. While you're awake, it's pumping, and it adapts to your behavior. When you're sleeping, it may be pumping relatively slowly and relatively softly. When you're exercising, or when you're agitated, or when you become frightened or excited, it's going to pump faster from adrenaline. It's going to respond, and the heart rate will increase, and the intensity of that squeezing will also increase dramatically. So it has this adaptive mechanism, but it never stops pumping. One of the things that's extraordinary to think about, if you think that let's say, average heart rate might be about 70 beats per minute. 60 to 70 beats per minute. That would mean that your heart is pumping 4,200 times per hour.
That's
Per
amazing.
hour, right? And so in a day, that's roughly 100,000 contractions in a single day. So in a year, you're talking about 36,500,000 contractions without rest. This is an extraordinary organ. Now, in a lifetime, let's say one were to live 100 years, then you're talking 3,650,000,000 contractions without ever taking a rest. So it's a magnificent pump. Well, how does this become important with the lymphatic system? Well, this pump is pumping oxygen and nutrients to our tissues to keep them alive. Now, some of that blood is going uphill. The heart is here in the chest, so one of the very, very important areas that the heart has to feed is our brain. Oxygen has to get to the brain. If the brain doesn't have a constant supply of oxygen, of course, you'll become unconscious. And if that persists, you can have severe brain damage, anoxic brain injury. So you could see how a strong muscular pump would be needed to go against gravity uphill toward the brain to keep you alive. On the other hand, we have what's called the aortic arch. The aorta is the biggest blood vessel that comes up out of the heart, and it gives up branches to your brain, the carotid arteries, and it gives branches to your arms, the subclavian arteries. But then it turns and it goes downhill. And this is where the conundrum starts to unfold for the lymphatic system. Under pressure, under high pressure, 120 millimeters of mercury pressure in systole, in the contraction phase of the heart, blood is being pumped downhill with gravity, along with the force of gravity, into all of the organs of your body, but eventually into your lower extremities, through your iliac arteries, into your femoral arteries, and then into the smaller arteries that go all the way down to your feet and to your toes. So blood is being pumped under high pressure with gravity into your feet. Now the trick takes place. Now this is the thing that is quite remarkable, especially for human beings, because we have a very, very unusual, almost unique circumstance in the mammal group of animals, in that we stand on two legs. So our heart is directly above our ankles, directly above our feet when we're in a standing or even a sitting position. So you have also what's called hydrostatic pressure. So you have the pumping pressure, you have gravitational force, which causes this hydrostatic pressure, meaning there's a column of fluid building up in the legs. So the pressure at the feet, the blood pressure, is very, very high in the arteries. 120 over 70, let's say, 110 over 60 if you have really good blood pressure, but that's high pressure. Now the question is, how does that blood get out of your leg and return to your heart? How does that circulation complete itself? And that's why we call it a circulation. Blood coming in the one side through the arteries and blood returning to the heart through the other side. This is a closed system circulation. Well, there's only really two mechanisms that bring blood back to the heart. One is muscular contraction of the lower extremities, especially the calf muscles, what we call the calf muscle pump. And those calf muscles almost act like two little hearts in your leg. So as you walk and as you ambulate, they're pumping, 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 and they squeeze the veins, squeeze the veins, squeeze the veins, forcing blood back up to the heart using the one-way valve mechanism that we have in our veins that becomes so important in venous disease, which is what I specialize in now. So there's that. But what if we're sitting as we are now having this discussion? What if we're lying flat and we're not using those muscles? Well, it's a very, very interesting physiological and anatomical process that brings blood back to the heart. And believe it or not, it's just the act of breathing. The act of breathing is what brings venous blood back to the heart by what we call a bellows effect. As we breathe, the chest expands, the diaphragm drops, the ribs spread, and the rib cage widens, and we create a bellows effect. We create a negative pressure, a vacuum, if you will, in the chest cavity, and that literally vacuums blood back to the right side of the heart. So that's quite a system, but it's
Yeah, you're not kidding.
imperfect. Yeah, it really is quite a system. Now, if we look at four-legged animals, which are the majority of mammals and even higher animals, reptiles and things like that, four-legged animals, you have front and hind legs with the heart sitting in the middle of in the chest, more toward the front legs, but certainly not directly above the legs. So there, in those animals, they have less of this pressure gradient, this hydrostatic problem with gravity pulling blood and wanting to keep blood in the legs. So we're really fighting our whole lives being in this erect posture, standing two-legged posture, and even the sitting posture, where we have this massive challenge of returning all of this blood back to the right side of the heart, to the right atrium, the collecting chamber of the heart. So you could imagine that that process is going to be imperfect. You're not going to easily get all of that blood back. So nature has evolved or created, or Mother Nature has created, whatever your belief system happens to be. Either way, there's a great system in place. And that system is our lymphatic system. And it's such an important system. So one of the things I did want to share with the audience tonight, and with the two of you as well, is this sort of graphic image that I've come up with in my mind to explain this to patients over the years. What I think of is, think about a driveway, okay? A blacktop driveway, which is perfectly flat. And you take a garden hose, which is a small caliber, relatively small caliber, and you lie it on the driveway. And you lay that hose on the driveway, and you open up the faucet full tilt. So you have high pressure water coming out of that hose. That is the analogy for your arterial blood flow. High pressure being pumped down into your legs. And arteries tend to be relatively small caliber as compared to the veins. The corresponding artery and vein, the artery is always smaller than the corresponding vein. For example, the femoral vein is much larger than the femoral artery. And that makes perfect sense, because you need a large collecting system for all of this high pressure blood that's coming in. So what I think of the veins as is, I think of it like a shop vac. A shop vac has a large aperture, and it's sucking, but it's not sucking with the kind of intensity that the water is flowing out of that hose. So you put the shop vac on the driveway, very, very close to the hose. And you hope that the shop vac is going to suck up as much of that water as it possibly can. But there's a little trick that most people don't know, a little nuance to the anatomy. At that point, and where the blood exchanges from the arteries to the veins, we call that the capillary bed. And we have little arterioles that are bringing the oxygenated blood to the tissue, releasing oxygen into the tissue, keeping it alive. And then the blood and the cells and the plasma and the serum has to cross over into the little venules. And the venules want to suck up that fluid to return it to larger veins and ultimately to the right side of the heart. That system is not sealed. it's not sealed tight. And there's a reason for that. If it were sealed tight, you couldn't get the exchange of gases and so forth. You couldn't release the oxygen into the tissue. You couldn't release sugars and nutrients and things like that into the tissues to keep the tissues alive. So there has to be a tiny gap. It's very tiny, but there's a real gap between the arterioles and the veins. And in that gap is where we get leakage. That's where we get leakage of fluid into the soft tissue. And those veins are not perfect in bringing up, sucking up all of that fluid to keep the soft tissues, the fatty tissues in the case of the lower extremity, completely dry, completely without edema. So the third part of the system, if you think about our blacktop again, our driveway with the hose and the shop vac both going full tilt, but now we're seeing some water collecting, a little bit of water, puddle collecting on the driveway. Well, what are we going to do about that? We bring a little sump pump. We bring a sump pump and we place it near that system. Everywhere that system exists, we put a sump pump right next to it to slurp up the extra fluid. And that sump pump system, in my mind, is the lymphatic system.
That's interesting. I've never heard of it explained that way. That's really interesting.
This is an original, Eric. This is my own idea,
it.
my own concept. Yeah. In fact, I've spoken to Dr. Mark Moline, who you know very well at Mayo, about maybe writing this up for one of the journals as a teaching aid. But I think that's a great way of thinking about it. And I think that's exactly what Mother Nature has done, is created that sump pump system to collect any overflow from that imperfect exchange from the arterioles to the venules. And so we have two concepts there. One is, again, as I explained, the circulation, the traditional circulation, arteries and veins, is a closed system in the sense that it starts from the left side of the heart, high pressure flow going to the legs, bringing oxygen, and then the venules picking that up and going to larger and larger veins and emptying back into the heart. So it's a closed system. The lymphatic system, on the other hand, you'll often hear referred to as an open system. And what that means is it's only starting in those soft tissues, all of those little sump pumps, all of those little lymphatic capillaries are starting in the soft tissue, open-ended, and they have very specialized valves, valve-like structure, gaps between the cells that allow that excess fluid into the lymphatic vessels, the tiny little lymphatic capillaries, and they bring those excess fluids and materials, including any kind of contaminant, a bacteria, a malignant cell, a fungal cell, a viral particle, etc. They collect all of that material and fluid. And now we understand why the lymphatic system is considered sort of a hybrid of two systems in the body. One being the circulatory system, because it's heavily engaged in managing the extra fluid in that circulation, but the other is the immune system. It's part of our body's lymphoid system and immune system, so that those vessels, unlike the veins that are just purely tubules that get larger and larger and carry the oxygenated blood back to the right side of the heart, the lymphatic system is not just simple tubules. It's interrupted along the way by lymph nodes. And those lymph nodes are immunologically active components of the immune system that contain various cells, white blood cells in particular, that have the capacity to entrap and destroy foreign particles, as well as modulate immune function and create antibodies and things like that to have a more complicated immune defense. So So that's, I think, a good place to start our conversation, is just that fundamental structure and relationship between the heart and the full cardiovascular system and the lymphatic system, which is both circulatory and immune in nature.
So that
Dr.
was
Chuback,
great. Go ahead.
yeah, I was just gonna say that's such a great analogy, the way you explain that. I've never heard it. And I think any of us who've lived in the Northeast and have had a basement, we've had that experience with the sump pump and the vacuum and trying to figure that out. I'm curious, I have a question for you. So you talked about the immunological component of the lymphatic system. Is that why we see patients who have a lymphatic component start to deal with more bouts of cellulitis or infection? Is it have to do with that, inability for those waste molecules to be brought to the lymph node? Because you kind of alluded to the fact that there's this waste material that kind of gets into the interstitial tissue space there, and then the lymphatic system should remove it. But in situations where there is lymphatic disruption, is that why we see some of these patients dealing with more infection type related issues?
Absolutely. And so the lymphatic dysfunction can take on several forms and have several causes. One would be physical disruption, for example, where by a number of mechanisms, whether it be surgical intervention, trauma, injury, etc., the lymphatic vessels are either completely transected, meaning cut, or they can become scarred from an injury, and clogged and blocked with scar material. So anything that's going to disrupt the normal function of that sump pump mechanism is going to affect not only the fluid collection, the edema that's going to result from that, but as you said very, very correctly, also have an effect on that immunological function. So again, to your point about, let's say, a flood kind of situation in a basement here in the Northeast. Let's say, for example, you had a situation where there was heavy rain, and mud and water and everything got through, let's say, a crack in the foundation. So you have your sump pump. So your sump pump is trying to go full blast. There's nothing wrong with the pump itself. It's plugged into the wall and you can hear the motor going. But think about those openings, the grate at the bottom of that sump pump that allows fluid in, but is trying to keep large particulate matter out. After a period of time, that's going to become clogged with debris, with sticks and leaves and things like that. And now suddenly, although your pump is trying like heck to do its job, because it's obstructed, it can't pull any more fluid. It can't pull any more water. So that's one of the problems. Now, another one of the problems would be, as you know, either what we call hypoplastic or aplastic lymphatic system, meaning that the lymphatic system itself, as sort of a goof up of the human body in its development, in what we call primary lymphedema, the lymphatics in that area may be either just too few, not large enough, not numerous enough, or absent completely. So again, you have a big basement, you might need 6, 8, 10 sump pumps put in different areas of the basement to manage that amount of fluid. If you need 10 and you only have 4, well, it's better than having nothing, but you're going to see more water collecting there. So anytime you have insufficient lymphatic drainage, then you're going to have a buildup of whatever toxins or noxious materials are in that fluid for whatever reason. And then you have a propensity, again, for something like cellulitis, cellulitis is just a very sort of fancy way of saying inflammatory and or infectious process of the skin and the soft tissues. But yeah, whenever you have dysfunction there, you're going to be more prone to that kind of thing.
Your opening
Interesting.
remarks. You go ahead.
Please go ahead.
Yeah, but you were about to say something brilliant there. And if
I was going to say that it becomes a bit of a vicious cycle. The more dysfunctional the system becomes, then the more debris that you have left in the tissues to be managed, and that greater tissue is only that greater material, using the sump pump analogy, is only going to clog the system faster. And one of the places that we see that, I think a good analogy for that would be when we see proteinaceous or proteins that spill into the soft tissue that have in themselves an inflammatory action and want to hold on to fluid and cause inflammation and cause scarring. So once you start to have dysfunction, that dysfunctional system feeds upon itself.
Wow. So I'm really kind of glad you didn't have a PowerPoint, because you're just flowing with all the years of experience that you have here, and we feel so appreciative of that. Our audience has some questions that they'd like to ask you, and I want to encourage the audience, keep putting them in the Q&A, because you're on the firing line now, Doctor. So question from Lisa Fiedler, and we're so glad that you're with us tonight, Lisa. Have you seen an increased heart rate in patients with lymphatic disease?
Well, it's a good question. I would say that that's certainly a possibility for a number of reasons. I would say probably the most logical physiological explanation for that, if somebody is finding that in their own situation, would be that, again, using a lot of my own clinical expertise and experience combined with my knowledge of the physiology of the cardiovascular system, if you become somewhat deconditioned in terms of your cardiopulmonary function as a result of lymphedema, because the legs are heavy, because the legs become enlarged, and mobility becomes an issue, it's a little bit counterintuitive, but because you would think, well, if you're at rest, your heart should slow down. And generally, that's a normal physiological response. But if you become deconditioned so that you're not getting enough aerobic exercise and mobility, and the heart isn't being exercised in a normal way, and the lungs aren't being utilized in a normal way, then because the system becomes a little bit inefficient in its function, the heart tries to compensate by going a little bit faster than someone who is well conditioned. So I think a good example of that, which most people would probably understand and relate to and have experience with, is the highly conditioned endurance athlete. These athletes who do tremendous amounts of aerobic exercise, where during exercise their heart rate goes up and the contractility goes up. So those are the two big things we look at in cardiac function: is the rate at which the heart beats and the strength with which. Okay, so what we call chronotropic and inotropic response. Chronos meaning time, and the inotropic component being how hard it squeezes. But those top athletes who bring their heart rates up to high levels under intense exercise, when they're really training hard or racing, and really pushing themselves to the limit, their cardiopulmonary system becomes so efficient and so highly functioning that when they're at rest, they get abnormally low heart rates. It's not unusual to find um, a world-class athlete, endurance athlete, with a resting heart rate of 35 or 40, where normally anything under 60 is considered pathological. It's considered bradycardia and would have to be looked at. But if you look at marathoners and super marathoners, many of those people are at rest with a heart rate of 35, and when they sleep, it could go lower, 30. I mean, as a cardiac surgeon, when we would see these patients, it was a little bit nerve-wracking at first. You were saying, "My goodness, I hope his heart doesn't stop." But it's because the heart is so strong and so
Wow.
conditioned, it has to do very little work to satisfy the body's needs at rest. On the other side of the spectrum, if you become significantly deconditioned as a result of lymphedema and lack of mobility, exercise, etc., it is possible that the heart rate could increase. And that could also be a sign that it's not squeezing nearly as hard as it should under ideal circumstances, which is why I think one of the best things for anybody, this is general health advice, but anybody with lymphedema, lipedema, etc., should do everything in their power to try to get on a walking regimen and increase their duration and speed slowly but surely to improve their overall cardiopulmonary function and endurance.
That's an excellent answer. And in fact, I remember when I started interviewing lipedema patients back in the day, they were told not to move, which was a fallacy. And some of the most amazing women I know said, no, that seems wrong. And they started Lipedema Fitness, which is a really popular Facebook and Instagram group, and they are getting stronger and they are walking. And so I'm so glad for what you said there, and I'm going to share it with them as well. A follow-up question from Lisa Fiedler. Do you notice short PR intervals? And you may want to explain that for our patients, maybe who aren't medical professionals in the audience, or an increase in tachycardia in patients with lymphatic diseases.
Well, those are great questions. The PR interval question I can't really answer because I'm not looking generally at EKGs. And what she's referring to is in an EKG, the tracing reflects the electrical function of the heart and the relationship between the atrial contraction and the ventricular contraction. And that timing can sometimes be shortened and sometimes can be lengthened. So I have to admit, I don't know the answer to that. But in terms of the tachycardia, I think that goes back to the first question, that I wouldn't be surprised at all to find that some of the patients with chronic and significant lymphedema might be a bit more tachycardic. And I wouldn't expect them to be truly tachycardic, which by definition means over 100 beats per minute. But I would expect many of them, I wouldn't be surprised if they were on the higher end of the normal range, so at rest, let's say up in the 80s or low 90s. And again, that is going to tax the heart. That's going to put undue stress on the heart. In other words, if you're sitting at rest with a heart rate of 90 or in the high 80s, well, think about how much more work your heart is doing. It's behaving at rest as the next person's heart might behave under moderate exercise conditions. So I have a very dear friend and colleague who's a brilliant cardiologist, and his father was a cardiologist. And he always jokes with his patients, you only get so many heartbeats in your entire life. Let's do whatever we can to save some for later. So if we can slow the heart down under normal circumstances, that is taking strain and workload off of your heart. And that's generally speaking a good thing for your heart.
Excellent. Thank you so much for that. Now, you did touch on this. And by the way, our audience is comprised of both patients and medical professionals. Chuck Ehrlich, of course, is a medical professional. He's been in the industry and working with lymphedema for many, many years. You did touch on this, but what else can you tell us about the role of the heart in lymph circulation?
Well, the heart becomes essential in the sense that all lymphatic fluid, which is collected throughout the body, eventually winds up in the larger lymphatic vessels. So if we use the lower extremities, for example, we have lymphatics throughout the lower extremities, and then we know that there are large basins of lymph nodes in the inguinal region, in the groin region, and also deep in the pelvis along the large vascular structures, along the iliac veins and the sacral area and so forth, the deep pelvis. So these vessels start as lymphatic capillaries in the soft tissue, as I said, as an open system, bringing collecting this excess fluid and any kind of particulate matter that might be present, and they coalesce, get progressively larger as they come up to the groin area, to the pelvis, and then there are basically two large lumbar trunks, a right lumbar trunk of the lymphatic system and a left lumbar trunk, which coalesce in the upper abdomen, just under the diaphragm, in the upper abdomen, as what is known as the cisterna chyli. Cisterna chyli is sort of a large collecting chamber that sits right on top of the spine, next to the aorta, which is the biggest artery in the body. And then from there passes through the diaphragm into the chest, into the thorax, and becomes the thoracic duct. And ultimately, the thoracic duct ascends in the posterior chest along the spine and finds its way to the left subclavian vein. So all of that lymphatic fluid, some lymphatic fluid does go to the right subclavian vein from the arm and the head and neck area, but the vast majority of lymphatic fluid will find its way to the left subclavian vein, where it re-enters the venous circulation completely, and through there it makes its way to the right atrium. And by that time, the blood has been tremendously cleansed because it has traveled through this massive number of lymph nodes and has been detoxified, so that when the blood gets to when the lymphatic fluid gets to the subclavian vein right here by your left collarbone and empties back into the venous circulation, it's getting dumped back into the main circulation. The immunological function of the lymphatic system has been completed, and now the circulatory function ends by dumping back into the vein, which brings it to the right side of the heart, which then goes from the right atrium through the tricuspid valve into the right ventricle, out through the pulmonary valve into the lungs, where it picks up oxygen again, and the whole process starts over. After picking up oxygen, it returns to the left side of the heart through the pulmonary veins into the left atrium, through the mitral valve to the left ventricle, and out the aorta once again to complete that cycle and that circulation. So the two systems are very, very intimately involved, starting from the capillary bed level and ultimately including into being released back, that fluid being dumped back into the venous circulation at the subclavian vein. And it's an ongoing, never-ending process.
Wow.
That was beautiful. You took us full circle through the whole role of the heart in the circulatory system and how it affects the lymphatic system, and go a nice, half an hour, 40 minute discussion. That's amazing. You made a nice loop there for us. Close the loop on the heart.
Yeah,
Yeah, it's amazing. We spent a lot of time in cardiac surgical residency, especially when we were doing congenital heart surgery, pediatric heart surgery, with all of the different anomalies of the heart, where babies unfortunately can be born with holes in the heart, in the upper chamber of the heart, the lower chamber of the heart, non-fusion of the heart, non-development of a chamber of the heart, etc. And we used to play this sort of intellectual game. If you were a blood cell, where would you go? Which way would you go? And you have to kind of imagine the whole circulation. But as you said, Eric, the circulation that we just described is that of the normal circulation. And those two systems, the cardiovascular closed system and the lymphatic open system, along with its immune function, it's a hybrid system overlapping two systems, circulatory and immunity, are just they work hand in hand and rely on one another for our health and quite frankly for our survival.
So
That's
that's what I
beautiful.
was wondering, because of the connectedness. And my original question is, what are some of the misconceptions or the things that people get wrong about this? How do you ascertain where the problem's coming from? Everything is so connected. What's,
Well,
is how do our medical professionals, how can we help them look for the signs better and how to treat better?
yeah, this is a great question. As you both know, we have the Lymphcast podcast where we focus on a lot of these pathological conditions, and we bring experts from around the country and from around the world to discuss that process. But generally speaking, Brenda, one of the things that I'm concerned about as a physician in America is we are we have now for a long time been on a downward slide away from good diagnostic work by the clinician. In other words, the ability for a physician to properly examine a patient on physical examination. Why is this so important? When I was in training, which is getting to be a long time ago now, I'm in practice about 22 years, and between medical school and my residency training, that was 11 years, 4 years of medical school and 7 years of surgical training. So you're going back over 30 years. That's 3 decades. 3 decades ago, things were not the way they are now. 3 decades ago, when I was in school, there was a massive emphasis put on physical examination. Now, things have changed so dramatically that the emphasis is on diagnostic testing, using technology and leaning on technology. Now, I have no problem with technology. I utilize technology every day, and I think it's absolutely remarkable and fabulous. But when I was in school and in training, the great teachers, the great clinicians, the great professors, medical doctors, surgeons, etc., they taught us that 95% of all diagnoses should be made by a good doctor by taking a good history from the patient, a thorough history, which requires talking to the patient, talking with the patient, and listening to the patient, okay, and hearing the patient. This is being lost. The history is going to give you 90% of what you need to direct your examination, right? So if a great clinician is starting with a good history, a thorough history, that clinician is going to ascertain and gather information that's already leading him or her in the right direction. And that next step is, okay, well, you've told me that your mother says your feet were swollen when you were a toddler. Your mother told you that your left leg was always swollen, not your right. You had an injury on a bicycle when you were 7. You had a hernia repair when you were 13. All of these things that we were trained very thoroughly in about your family history, medications, surgical history, allergies you may have, travel you may have taken part in, et cetera, et cetera. All of these clues, we ask these questions for a reason. You have to know what those reasons are, and then you have to know, oh, this is a problem. This is a problem. Oh, he had, or she had, let's say, breast cancer, and she had lymph node sampling, and now she has a swollen upper extremity. Well, that doesn't take Inspector Clouseau to figure out what might be going on there. Or a patient who was perfectly normal, it seemed, and then had a spider bite or a mosquito bite and didn't have sort of a normal reaction that another patient might have. Her mosquito bite or spider bite resulted in a massively swollen lower extremity. So perhaps in that case, there was a hypoplastic or underdeveloped, what we call subclinical lymphatic problem, but it was only when there was an injury or some outside toxin or infection that the system became overloaded and tipped us over the edge. So a good history and physical examination is essential in making these diagnoses, and then the diagnosis should be confirmed when necessary with diagnostic testing. But the idea that patients now present to their physician or they present to an emergency room, this is a general statement about the state of healthcare in the United States. And you go with abdominal pain to the emergency room and nobody examines you and they order a CAT scan of your belly.
Hmm.
That's not an improvement in healthcare. That's a disgrace. That nobody comes to look at you, take out a stethoscope, listen to your abdomen, palpate your abdomen, percuss your abdomen, et cetera, et cetera. If you're going for an ultrasound of the abdomen or going for a CAT scan of the abdomen, the physician who has seen you and evaluated you should be 95% sure what that test is going to show when it comes. Not a mystery like a black box. Oh, I wonder what he has. If that's going to be the case, we won't need doctors.
That goes back to the phrase patient care. When you care about that patient, you will ask those questions and be curious. I think that was brilliant. And I want to defer to you, Eric, as we're running out of time. Do you have any final questions for Dr. Chuback?
I do. I think that was so well stated. Just the role of a good history and physical and understanding, what a patient has gone through that may be creating symptoms. I'm curious about your thoughts with more preventative medicine. I know you've done a lot of work with nutraceuticals and products of that sort. Could you just speak to that for a moment? What your thoughts are about supplements that might help just overall well-being and health, especially in the world of lymphatics?
Well, I think that's a great question. I mean, certainly, again, for full disclosure, I started the company Vita Support MD 8 years ago because I came to learn about micronized purified flavonoid fraction and the role that it plays in the venous and lymphatic system and supporting good venous and lymphatic health. Dr. Monica Glavitsky, who's an MD PhD, who was at Mayo for years, did 15 years of research on that subject in Paris, France, doing a lot of the seminal work that showed that micronized purified flavonoid fraction, which is derived from orange peel, it's a naturally occurring substance that exists in orange peel, that it decreases capillary permeability, meaning it decreases that fluid leaching out and leaking out into the soft tissues and collecting there. And it also is known to increase lymphatic contractility, lymphangion contractility. So you have decreased fluid collecting and you have increased outflow, as well as some other wonderful mechanisms, decrease white blood cell adhesion at the endothelium. So to answer that question, yes, I believe strongly that supplements like MPFF, micronized purified flavonoid, are helpful and useful in supporting a healthy venous and lymphatic system. But I just, again, more generalized discussion to answer your question, Eric. I think that too many quote unquote allopathic physicians like myself, MDs, were sort of convinced in their medical training that dietary supplementation is nonsense. It plays no role in real medical care, that people who purchase supplements are wasting their money, that you're just flushing your money down the drain because we in America are so well fed that we don't have any dietary insufficiencies and so forth. Well, I'm just going to leave it with this, I think, other crystal clear example. Number one, we know that nothing could be further from the truth that supplements don't do anything. We know that if you don't get enough vitamin D, I mean, to an extreme level, you'll get rickets. We know that if you don't get enough vitamin C, you'll get scurvy. We know that if you don't get enough vitamin A, you'll go blind. So we know that these vitamins and minerals and micronutrients have a massively important role in the normal function of the human body. The other thing that we know is that the idea that obesity is an epidemic in the United States, I wouldn't argue that. But what I would argue is that because people are overfed, that doesn't mean that they're well nourished. On the contrary, many studies have shown that we as a nation, as a society, are overfed and undernourished because of what we're being overfed on. You're not going to get nourishment from Doritos and hamburgers and cheeseburgers and French fries and onion rings and Coca-Cola and Diet Coke and so on and so forth. So you can take in tremendous numbers of calories with very, very little nutrition. So many patients, even in the obese category, or especially in the obese category in many cases, do need supplementation. And the last point I'm going to say on that, if we look at the COVID pandemic that we contended with and are still sort of, seeing some of the tail end effects of, when my colleagues up at the University of Rochester and all of the big university hospitals that I trained in with big time academic clinicians on both the medical and surgical side of the fence, when they were faced with these people coming in dying from this horrific virus, when it was really in its most virulent, deadly phase in that first wave, and there was no antiviral drug yet, and there was no vaccination yet, what were they doing? Pumping these people with vitamin C, vitamin D, vitamin E. It was one of the only things that they had in the armamentarium. Antibiotics weren't going to work because antibiotics work against bacteria, not against viruses. So many of my former professors and mentors and educators who for years and years and years said, dietary supplementation, vitamins, this, nonsense, snake oil, wives' tales. Well, when the rubber hit the road, they were all calling for it, especially when they themselves got sick. Everybody was taking zinc, vitamin E, vitamin D, vitamin C. All of my colleagues in the big university hospitals, myself included. So I'm certainly a believer, and I think there's good reason to believe. I don't necessarily believe that you have to for a balanced discussion. I don't think that you have to push for supranormal levels. I'm not sure that 1 million international units of vitamin C is necessary, but I do think that you shouldn't walk around depleted. And I can tell you, I know I keep saying last thing. This is the last thing. For years, we had a medical weight loss program in my practice, and in that program, every single patient got vitamin levels. In hundreds and hundreds of patients, we never had a single patient with a normal vitamin D level, myself included. Everyone needs vitamin D supplementation, and not to prevent rickets, because we now know vitamin D is so instrumental in so many of the body's physiological processes and so on and so forth. So thank you for the question. I think it's an important subject.
And it's a great answer.
I know for myself, I'm not a huge supplement taker, so I just moved to Florida to deal with the vitamin D nutrition.
Just make sure you have a good dermatologist.
Yeah.
Good response. Good response. So time is wasting, and we do have another question from the audience. And then I do want to end because my watch has said it's time for me to stand. And you talked about the importance of exercise for patients that can't necessarily move around a lot. We know that you use the Lymphapress pneumatic compression therapy, and it helps to pump the lymphatic fluid. Anything that you'd like to say about the use of the Lymphapress with your patients?
Well, again, this isn't a quid pro quo of any kind. This is unsolicited. In fact, I'll be honest with you, I almost forgot that the interview was being done by the Lymphapress folks. So it was such a nice discussion. Eric knows, I mean, you all know, I've been using the device very, very liberally for years. And the only thing that's happened in my practice in the last couple of years is I'm seeing more and more indications for it. I'm using it more and more liberally as patients are seeing better and better results. I'm a great believer in graduated compression. Unfortunately, many patients can't tolerate it because they're arthritic. They can't get it on because of their hands. They can't bend over to put it on. Their body habitus doesn't lend itself to compression. So many patients, it's the Lymphapress pump is their only viable option, and I've learned to use it liberally in those situations. And then, of course, in my patients who can use graduated compression, I use it wherever indicated, because I think it's a great adjunctive device once or twice a day. I like to get them to use it twice a day if I can, but at least once a day to really help mobilize that excess fluid. And it's a thing that patients enjoy. It's not, it doesn't seem punitive. It doesn't seem like a punishment to them. Whereas unfortunately, graduated compression stockings often do feel a bit punitive. So I love the device.
Thank you. Thanks for saying that. And we never want these to feel like they are an advertisement for Lymphapress. In fact, I just put a link in chat for everyone. We are offering content every month, several times a month, whether it's for your patients or whether it's for the medical community. Just click that link and it will take you to all things Lymphapress. One final question from the audience, Laura Middlestead. Thank you for being here, Laura, and thanks to everybody who logged on tonight. We appreciate you, and especially you, Dr. Chuback. Laura has noticed that her patients that were treated with cervical radiation for head and neck cancer have a strange dizziness. Those are the symptoms that they're experiencing. Could this be because the I'm going to say this wrong, cardioid baroreceptor was damaged?
The carotid baroreceptor.
For that one. That's the one.
Yeah, that too, right? Yeah. It's an excellent question. I think that there is a possibility that's associated. Anything in the head and neck, things become quite complicated. Dizziness can often also be associated with inner ear, middle ear kind of problems. And so the folks today, in terms of radiation therapy, are extremely cautious and good about protecting adjacent and surrounding structures, but it's it's an imperfect thing, of course. There can be damage to surrounding structures. And I think that that's, again, not something I have any personal knowledge or expertise on, so I can't comment, but I think she's raised a very, very interesting point, and a good radiation oncologist might have an answer for her if there's anything specific to that injury from radiotherapy in the literature. And I wouldn't be surprised if there is. It's a great question.
Mm. Well, I was the lucky one tonight because I had two of my favorite people on the screen with me. Eric Ansart is the president of Lympha Press. Thanks for being here tonight, Eric.
Oh, this has been wonderful. Dr. Chuback, I can't tell you how much I appreciate it. I really enjoyed this conversation.
Yeah. And thank you,
Thank
Dr.
you.
Thanks.
Any final words for our audience, Doctor?
I think the last word would be, there is always hope, and there's a lot of help out there. And keep looking. The same thing we say on the Lymphcast podcast. If you're not satisfied with the results you're getting, if you're not satisfied with the care that you're receiving, get another opinion. Go online. We live in a golden age. We have so much. Here's where technology can, again, really help. Look for people with great reputations. Go for second and third opinions. Keep looking for that group of clinicians, therapists, and others who really can help you. The second piece would be, if you can walk, walk. My dear friend, Dr. Barry Franklin, up in Detroit, who runs the big cardiac rehab program there, he tells us that the person who can run 5 miles, who extends to 6, has done very little to improve their health. But the person who's sitting on the couch, practically immobile, who can start to walk 50 and 100 feet at a time, has done something dramatic for their health. And that's not an opinion, that's science. So don't think, well, what difference would it make if I did a little bit of walking 5 feet, 50 feet, 1 block, around the block? All of those little improvements, those baby steps, are having a massive impact on your cardiovascular health and your lymphatic health. So if you're in that condition, please, walking is the best medicine.
Fantastic. This has been an amazing hour. We're so glad you joined us. Thank you, Dr. Chuback. And I love the ending. There's always hope and there's always help. And if we at Lympha Press can be of service to you in any way, please don't hesitate to reach out. Thanks, everyone, and have a great night.
Thank you.